And welcome to the National Patient Safety Office Conference QPS TalkTime special. We're delighted to welcome you this afternoon, and we're going to introduce some wonderful panelists who are going to share a little bit about the conference. And we also have this time some participants in the poster competition who are going to share some of the work that they've done. The theme this year is nurturing a positive culture of patient safety, listening, learning and responding. And just in terms of the session, we're going to learn a bit about the National Open Disclosure Framework with our co-host, Dr. John Fitzsimons. You'll hear about the theme of this year's strategy, this year's conference, I should say, and you'll also, as I said, get a taste of some of the poster submissions. As we begin, and we'll introduce the speakers as we go, and you'll have seen the bios in the poster that's there. But I'm going to introduce now Kate O'Flaherty, who is the Director of the National Patient Safety Office. And we might just start with, if you could tell us a little bit about the conference and particularly the theme this year, what we've heard so far and what's coming up this afternoon.
Thanks, Juanita. It's great to be back with QPS TalkTime. I was with you for World Patient Safety Day just a few weeks ago, plugging the conference, and here we are today in Dublin Castle. So our theme is nurturing a positive culture of patient safety, listening, learning and responding. And a lot of that, I suppose, is the feedback and learning over the last few months and meeting a lot of people new in the role. This real sense that we're at the end of a chapter, the start of a new chapter, and people we're building. So a lot of your listeners and viewers, as I've just realised as well, will know the Madden report and building a culture. And I think a great sense here today that we've already built something, and now it's about how do we respond to the new challenges, how do we strengthen what we've got, and nurturing, because it is about partnership and positivity here today in Dublin Castle. So we've had leadership of the department and the HSE, but also colleagues from OECD to give the international perspective and the great work that they're doing there. And speaking about culture, and they have a pilot tool they've run in a few countries of how do you actually measure culture. And so I think that's maybe something we want to kind of think about here. How do we then benchmark and reflect our progress going forward? And I know you have some of our morning panelists here with you, but a lot of it is how do we maybe reframe and strengthen our ability to communicate and talk to each other and tell each other the stories of progress. And we do need some data for that and measuring that, and every tool that we can use to be continually listening and learning, as is the conference theme. So in the afternoons, you said we're going to be launching our first National Open Disclosure Framework.
Yes.
And I know the focus on open disclosure and honesty and transparency has been a big feature for the last few years in Ireland, is a really important element to people, patients and staff in Ireland of our culture. So that's a big kind of achievement again, and something to build on. And this morning's panel discussion, lots of new ideas about future challenges. So we talked about AI, we talked about end-of-life care, which I think you mentioned as well. So big, not just health challenges, but societal challenges. So a really busy and interesting day here in Dublin Castle. People really looking forward to the future, and positively, how do we strengthen and build on and nurture what we already have achieved.
Thank you very much for that insight. And just to say, for anybody that is interested, it will be possible to watch the full conference back at a future date once it's available from the recordings from today. But what I'm going to do now is hand over to Dr. John Fitzsimons, who's our co-host this afternoon. And John is going to introduce his panel. They're going to talk about the National Open Disclosure Framework.
Thanks, Juanita, and good afternoon to everyone. This is for all of you suffering from FOMO, because you can't be here today. So we're hoping to bring you a little flavour of the conference and some of the discussions. And there's a session on this afternoon, as Kate has just referred to, on the next steps for open disclosure. So I'm joined here by my panel. So first of all, I'd like to introduce Maurice O'Donnell, who's the head of patient safety legislation and advocacy at the NPSO. Bernie O'Reilly here to my right from Patients for Patient Safety Ireland. To my left, Lorraine Schwanberg, Assistant National Director, Incident Management Team in the HSE. And then Angela Tysall is joining us as well, HSE Lead for Open Disclosure and Incident Management. So we're going to try and give you a little flavour of what's going to be talked about this afternoon. And Maurice, I might start with you. We've had open disclosure for some time, but today sees the launch of the National Open Disclosure Framework. How have we gotten here?
That's a very good question. And I was just talking to Andrew and Lorraine earlier about this sort of thing. Open disclosure is something which is an integral part of the health system already. And it's something that is done kind of up and down the health systems. What we're trying to do today is just make things a little bit better and standardise it across the entirety of the health sector. So there's been a number of initiatives by the HSE and by the department in the last couple of years. Earlier this year, we had the Patient Safety Act, which is an important patient safety legislation. It brought in a number of measures. One of them was, for the first time, specific measures regarding open disclosure for some of the most serious patient safety incidents. What we're doing today with the open disclosure framework is another side of the same project. It is the open disclosure framework, which is a policy answer. So for everything right across the health sector, whether it's public hospitals, private hospitals, regulators like HIPAA, professional regulators like the Medical Council, it just sets out, this is the standard, this is what's expected from you. It's not prescriptive. It doesn't say, in case X, you have to do X, Y, Z. It kind of sets out, these are the broad principles. Now take them away, put them into your policy. So it's just about doing what's being done better.
Yeah. And it's very clear that it's across the whole of the health service stands. Yeah.
Absolutely. Everybody, public, private, the different educators, that's a very important, it's a very important bit. Talking to colleagues from the HSE earlier, we were discussing the importance of leadership in kind of this area. And that's not just for, clinical directors of major hospitals. That's in GP practices. That's in educators, that they are making sure that everybody who passes through their door has done a module on open disclosure, understands it, that it's baked into their training material. So absolutely, everybody, every part of the health sector is included here.
We've heard a lot of talk this morning already about partnership. So what's the department's role in this partnership for seeing the successful implementation of the framework?
It's very much a partnership role. As I said, it's not a prescriptive document where we're saying you have to do X, Y, and Z. It is saying these are the things that you need to have reflected in your policy. The department's role is, to a little extent, checking the homework. Each organisation will be obliged to have their own open disclosure policy. Like the HSE has an excellent open disclosure policy, it would be replicating that on a different scale throughout the different organisations. The department's role will be, as part of the framework, once it is embedded, every organisation will have to report on an annual basis on what they have done to implement open disclosure, how they are carrying out the open disclosure principles in their own policies. Requirements will differ for different organisations. It's not a one-size-fits-all solution, but what is one-size-fits-all is there will need to be reporting on it, and then within the department we will aggregate all of those reports and we will be able to present to the Minister, this is how it's going. This is really going well. It's maybe we need to put a bit more effort into the communication piece, etc. So that would be the role that we see for the department in it.
Great, thank you. Angela, I'm going to ask you, you've obviously been working in open disclosure for many years. How is the framework going to help you?
First of all, I'd like to say that we really welcome the publication of the framework, and it is informed by the HC policy, it aligns with the HC policy, but it really reinforces a lot of the messages we've been giving around open disclosure for the last number of years. I think importantly for me that this policy now is going to be across all the health service, because patients should have the same rights to open disclosure for a public service or in the service. So it's really important for that. And I think on our own agenda, like I'm at the end of my 13th year right now on the open disclosure journey and the HSE, and there's some really big agenda items for us that I think this framework is really going to help to drive, like keeping that ethos open disclosure, that is that caring, compassionate and empathic response to patients, their families and to staff, in the autumn patient safety. And so there's a bit right around for patients to understand also, but also that it is of keeping the patient and family the centre of everything, and that's really strong in the framework as well. And things for us that are very important is the whole training perspective around open disclosure, and there's a real leader again, but to the importance of that training. You mentioned already leadership, and we're really seeking, to get more leadership and particularly clinical leadership in our with our acute and our community services. I think as well the whole area around performance assurance, and that's we've been working a lot on that for the last couple of years, and has been added a lot of that, but just to be able to measure the successful disclosure, having some KPIs around it, and measuring, for me, the most important measurement is measuring the patient experience. So all those things, the framework will help to drive for us going forward. And the other big thing, and we're always talking about it, is about the importance of documentation, of open disclosure. We've seen some excellent examples of open disclosure across our healthcare system, and unfortunately, we don't see the documentation supporting that. So again, this framework is pushing that whole area of documentation. So really positive to that from my perspective.
Great. Where can people get a hold of this? Obviously, we've got some copies here. It is available online now, and
It's available online as of today on the department website, and we'll make sure that Juanita has all of the details.
yeah, you can put that up.
Yeah. And there's also an email address for people who have queries about the framework, which is just open disclosure framework at health.gov.ie. But we'll make sure that the team has all of those details as well when this
Super.
goes up.
The theme of today's conference is about nurturing a culture of patient safety. How does this align? How does the framework align and help that work? Because I know within your work, there's a lot of focus on culture.
Yeah, and for me, I suppose, again, to congratulate the department on the framework and putting it all together and having a systems approach to implementing open disclosure, which I think is a really positive development. It has 6 principles in it, and one of the principles is very much around culture element. And, a lot of focus is on leadership there. For anyone who's missed the conference today, we had some very strong messages, I suppose, from our leadership teams within a system from Verling Gloucester and from Robert Watts within the department, and the panel discussion was very strong. So we know we have the backing and the drive from our senior leadership teams within the system, and how that transcends then is very important. So the framework in particular, which we're very delighted about, shines a light on just culture as well. So how our staff, I suppose, are interacted with when there is an incident, that there isn't a blame culture, that we recognise that there is a system often, or there's system issues that might have led to an incident. And it also calls out the need for clinical leadership and having champions in different areas. So we know we have the support at the top level within the organisations, but really to mirror that. And I know Angela and the open disclosure team have a fantastic network of open disclosure, needs to really drive the message home to the local organisations within the HSE. And for that to be mirrored across the system would be fantastic for culture.
Great. Thank you. Bernie, I know Patients for Patient Safety will welcome the launch of the framework. What are your hopes that the framework will bring?
Well, we all basically trust our healthcare professionals, and part of that trust is honesty. And I'm not saying there was never honesty, there was oodles of honesty, but this is just going to bring it to a new level, hopefully, and that we'll have. I'm just thinking of the learning. That word learning jumps out from the theme this morning. I'm listening, learning, responding. Well, so much of the learning is in the open disclosure process, and of giving people that supported environment to make those disclosures, to be honest with patients, and to capture all those individual instances, which, sometimes seen as one-offs. But if you study them, there's probably so many of them,
and you can't actually learn if you're not listening. You can't learn if you don't learn, you can't respond. So I'm hoping that open disclosure, this framework, and the fact that it covers all of our health services, it's not just HSE services, it's all of our health services, and the fact that everybody has to do a report back into the system, so it'll be monitored. So audit is really important, and monitoring is really important. And just I'm hoping that in time we're going to be instead of telling the stories of bad outcomes and poor results, that we're going to be hearing results of people who've had positive experiences, that patients have had positive experiences without disclosure, and there'll be good stories. We're always going to have poor stories, but it'll be good to have the balance of hearing the good stories, because there's so much good in healthcare. And it's back to what was discussed this morning at the conference, that there's negativity in our health service. Basically, we have a good health service. It doesn't always meet the demands of people, or it doesn't, and it fails people. To be honest, now, this, like, my husband was failed in the system, our family was failed in the open disclosure process. But going forward, I think that it's good to have something now that shows a positive way forward, and for people to be supported in their honesty. Like, staff will be honest if they're not fearful, or if they're not worried about making disclosure. So plenty of support for staff, because we need our staff in that safe space of being able to share these incidents with us and keep us informed and go the journey with us. Like, I found it very difficult to engage with the health service, and I lost my trust in the health service because of my journey trying to get answers around my husband's care, and it went on for too long. And my husband has been dead for 17 years now. And I'd like to think that we mightn't have totally arrived, but that we're way further up the road than we were 17 years ago. And I've been watching this space for 8 years, and I've seen it developing, and it's always been getting better and better and better. And I think this document now might be just, it's going to give it that extra little bit of push.
Thank you for that. I think we all share that hope. And I think, the last of those words today, in listening, learning and responding, I think brings up the idea of, if we respond, we have responsibility, and I think we all have responsibilities to see this framework implemented. So thank you all, panel. And I'm going to hand back over to Anita.
So that's it. Thank you very much, John, for that. We're going to have a big conversation about the morning parallel, which is learning. And it was quite an extensive panel. It was quite a large panel, actually. But we have 3 people here with us. So we have Kate O'Flaherty, who's the Director of the National Patient Safety Office. We have Rachel Kenna, who's the Chief Nursing Officer. And we have Katie Verling, who is a member of Patients for Patient Safety Ireland. And thank you very much for joining us, because we know that they literally stopped the panel at 1 o'clock and then made their way here. So they haven't had much of a chance to have a break. So just Kate, this morning's session focused on the desire to have that culture of patient safety, and there's a lot of those aspirations that are outlined in patient safety strategy, in mission statements and value statements. But how do we marry that with the actual reality of the day-to-day work, and how do we make it happen in real life?
Yeah, so there's a strong sense in the room, really, of the energy and the desire for that. So, and I think the panel spoke really well and covered a lot of topics about taking that systems approach for consistency. Because I think, just going back to the open disclosure framework and Bernie's words there, it's about how do you make it the norm, and then it's not, I suppose, as big and anxious an undertaking for people that this is normalised and feel supported and it's integrated. So the panel talked a lot about bridging that gap, not only between the individual patient and the system, and how do we make all of that a reality and support people and implementation implementation science and implementation of getting what's on the page into real life experience, but also through the human connection and reducing the anxiety that often people feel, the vulnerability. There was a strong sense in the room, and many of the speakers spoke that no matter what hat you're wearing on the panel, from the leadership all the way to the front line, we're all patients at one point or another. And how do we almost harness those pieces. So the positivity that we feel, our experience, how do we harness that to improve outcomes?
Yeah, I think one of the things that struck me was looking to see where there's good example, that you can focus on the positive deviance and the sort of sense of how you make it work there. How is that? What's the difference?
What does it look like? How do you communicate that? And then how do you integrate that into, yes, we need that balance between regulation and enablement. And obviously training is a big part of that. And communication and work that you yourselves do in QPS through the various kind of work streams. But a lot of it is what's the right balance of that so that people can feel empowered. So we didn't use the word empowered, the word to do with agency a lot and agents. But how do people feel the agency and the confidence to do the right thing, to feel confident that they're doing well, for a patient to feel confident that I'm listened to, I understand there's risks, there's limitations, things are not perfect, but I feel like a real partner in this tricky, interesting, often terrifying experience, which is my healthcare. And you're right, we have to govern that and regulate it. So we have documents and strategies. We need data, intelligence, etc., to be able to kind of measure and get feedback both from that and people's stories, listening to our staff, a lot about listening not only to patients but to the staff who are often telling the same story as the patient in a slightly different way. And how do we bring all of that together to kind of improve our collective intelligence so that we can collectively respond better and feel that real sense of partnership. And I think there was that sense, one of the speakers on the panel, that sense of partnership requires that level of community, trust that Bernie mentioned, of solidarity, and everything that we do, I suppose, is try to frame it in the lens of how do we help make that easier for the individual people working in the system and all the thousands, hundreds of thousands of people walking into the system every day to get care.
And it's interesting, you did mention the data, and there's that old piece about what gets measured gets done. And with culture, it's one of those things, it's like the nebulous hugging a cloud, as somebody's described it. And it is that sort of, how do you actually measure something like culture? That came up this morning. Would you like to touch on that?
I did. I suppose when I came into this role a few months ago, and in Ireland, culture is it's an important kind of way that we seek to express and to drive, not only in health, but other things. So it's like, how do you measure culture? So I thought it was nebulous and that I was going to have to hug a cloud. But no, the OECD, who are here to talk about their work, they've developed early, it's been piloted in some countries, but tools and surveys to actually start measuring that culture. So I think you can measure it. And it may not be perfect, and it'll be an important part of learning. So I think that's something we want to explore, particularly now as we go on the next chapter or moving to regions, there's kind of big changes. I think keeping the core, because there was a lot of talk this morning as well about what we do well and keeping what we do well and building on it. So measuring our culture and tracking that over the years may be a very interesting way, an additional way to give us feedback about what we're doing well and where we can learn from each other.
Yeah, it's interesting you talked about that sense of it not necessarily being perfect. And, Bernard Foster spoke this morning about perfect doesn't necessarily get it done. We sometimes have to just start and acknowledging that it's not perfect at the moment, but moving it on. And just speaking about that OECD report, thanks very much for that, Kate. But Rachel, Ria and Fujisawa, and I don't know if I'm saying her name correctly, but she's a health economist and a policy analyst with the OECD. She spoke about a patient safety culture as defined by the European Society for Quality in Healthcare as a pattern of individual and organisational behaviour based on shared beliefs and values that continuously seek to minimise patient harm, which may result from the process of care delivery. And at the moment, we have a very culturally diverse workforce. A lot of them are meeting in person. Some of them are joining online, and that's changed the dynamic. But also, I suppose, we also have staff that are rotating through the services. And when you think of that in healthcare, and you think about developing shared beliefs and values on which to form a culture, how can we do that? Or have you thoughts on that?
Yeah, I do. And it's a really important question, actually. And I think starting with Ria's presentation and the OECD data, what I learned this morning was that these are challenges for a lot of countries across the world. And that's, you know, I accept the challenges with comparisons, but there are certain threads there that we could see that every culture, and that means the cultures that our staff and our workforce have come from, have also grappled with these problems and challenges in their own countries. And there's huge learning from that and what they will bring. And that integration of cultures and that diversity is really important, because our patients are also from a wide range of countries now and different cultures. So learning how to communicate in that broader context is really, really important. And the data is critical, and the way that we look at that and see what story that's telling us. The other thing to remember about it is that whether you're a nurse in Ireland, India, or Colombia, we heard this morning, which actually had some interesting stats about them. Whether you're a nurse or a doctor in those countries, regulated professionals have codes of conduct, ethics and values and beliefs that transcend global boundaries, okay? So we already have leverage in that area, and we need to use it. And then finally, what I would say is the beauty of patient safety is that is a shared and common goal, belief and a value for every healthcare worker that gets up out of bed, and every patient that comes in has a right to expect that. But the key message for me this morning is that healthcare workers can't do it without the patients, and the patients don't want to do it without talking to us and telling us. And that's really important for me to take back and reflect on how you actually embed that in policy. It's almost as exciting as we can measure culture.
It's quite a new one, all right, in the sense that you've done this sort of thing, and everything is evolving the whole time. And there was something for me that really struck me this morning. It was that reminder that every single person in the room is a patient at some stage or other. So we're building a system for ourselves, which I think is really important to remember. And speaking of patients, so Katie, your patient partner, and you said something earlier on that really struck me, and it was to remember that patients can think. So, there's something, but very straightforward. And you sort of say, how could you forget that? So if you were to think about, what would a conversation with a patient look like in a culture of patient safety, where that happened as the norm? What would it be like?
I think, first of all, you do actually need to establish how much the patient is calm and can actually listen.
Yes.
Because it's something I'm tremendously conscious of when I'm trying to deal with computers and fix things or go online to do something. And I get more and more stressed, so I can no longer see what I'm doing. And I think that knowing the level of anxiety in itself is a way of managing the situation. And then addressing that and trying to bring everything down to a calm level. The other thing is that we naturally feel anxious when we go to a doctor because something is wrong. We could be in pain, we could be really suffering. We could also be catastrophizing like crazy. And this is very much part of the conversation, and we've got to be aware of that always.
Yes.
Even with the third sore throat in a row is this throat cancer. The other thing that's really important is to establish to what extent the patient has medical literacy. And we now know that at least 40% of the Irish population has poor medical literacy.
Yes.
Really no medical literacy. And that's something we have to address through both the Department of Health and the Department of Education. That is something that we build into our system, that we get people more comfortable speaking about their bodies, speaking about themselves, and having a sense of ownership of their own bodies and their rights around their bodies. So they get to ask questions, and we can question what's going on. And I think all of those things of recognising the patient as an agent in their own care, and enabling that to happen will make for that concept of a collaborative engagement between the healthcare system and the patient. So it becomes, we're doing this together, and we're looking after ourselves together. Yes, things will go wrong, and it might be through no fault of our own, but we will try and do this together as a team.
Yes, it's really interesting. I don't think I really appreciated how challenging the issues were around health literacy until World Patient Safety Day, and the conversations around it at the time, and the people that you don't expect. And I was sort of thinking back to my old scenario. I've been at the doctor where you go, yes, 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 and you go out the door and you look up something and you sort of say, well, what exactly were we looking at there? Or you're trying to take in the information, and it's not really until you go later and go, actually, I didn't really understand that. Or you're looking at a leaflet and saying, well, what exactly are they asking me to do here? And I would say that I'm well able to, really, but actually in that scenario, it is different. It is different. I do think that's really important. So that's a really good suggestion. And if you were thinking then of, I know you've worked in arts management, you worked in policy development, you've studied things like medical ethics and narrative storytelling, and have won awards, and a whole, portion of your work was around culture, and obviously a little bit different than healthcare culture. But if you're thinking of developing a positive culture, have you some thoughts or suggestions for us around building that culture or that sense of a positive culture for patient safety?
Recently, I've developed this big interest in narrative medicine, and realizing it's also, but it comes from the analysis of literature and all that, the storytelling, and the central element of any engagement between a medical professional and a patient is a story. And recognizing those stories and seeing those stories and hearing those stories.
Yes.
And there was a very interesting piece of research done recently that if a doctor, in a doctor-patient engagement or nurse-patient engagement, if the doctor keeps on asking questions, you won't get the information. Whereas if you give the patient all the time they need to explain themselves, they will run out of talk after 90 seconds. It's amazing. After 90 seconds. And then you will have learned an awful lot more than if you kept on interrupting them. And I was just reading a piece of wisdom the other day about, we are so busy coming up with the next thing we're going to say most of the time. We're not listening. So learning to listen is absolutely key in how we improve patient safety and we improve the engagement in the medical system. And all of us need to improve our listening skills. Yeah. All of us, all the time. So I think the question of and the other thing in kind of the narrative is that as all of us are patients too, and have had to look after children or in parents, whatever, we all have that knowledge. And if we reflect on that and bring that into our practice as a medical professional, we behave in a more compassionate and empathic way. Because we're no longer passive, passing on a service. We're actually bringing ourselves into the engagement in a safe way, but I'm doing it in such a way that we are trying to make it better, because we would want that to be the same for ourselves.
Yes, yeah. That piece about the timings of consultations, and in particular how long things take. There was a really good book, Time to Care by Robin Davis, and I know I've mentioned it on this group before. That it just struck me, that sort of sense of what you want to know today. What would you like to know? And rather than trying to force feed people information that maybe may not be the uppermost in their mind, but the bit for me that struck from your conversation was checking in first to see where somebody's at, so that actually if you start the conversation, can they hear you to begin with? And do they need somebody with them to have this conversation? That does change it from a patient safety perspective. We're going to go in a second over to John. And one of the things that we're going to do is have an opportunity to listen to some of the poster presentations that are coming in. So with that, I might just check in. Are we okay to start in a moment? Yeah, I think we're ready to go. You'll hear a little bit of bustling. This is the first time that we've done it like this. So you have to forgive us as we get the technology, and technology is always beautiful. But you'll hear a little bit of noise in a moment as a few of our colleagues join us to share some of their posters. And just to say thank you so much to our panel. I know that at the conversation this morning, if you do get a chance, it is really worthwhile to listen back to it when it's made available and it's publicised. So thank you.
So, good afternoon. Marie, Manaz, and Eva, you're all very well. Would you tell us a little bit about what you've been doing. Just ask her, Marie, what is human factors?
Yeah, so it's great to be able to showcase human factors again, and it's been talked about in the conference. So human factors is the science of design. So how do we design systems, processes, products, whatever it is, with safety explicitly in mind? So how do we design to optimize the healthcare system performance and human well-being? That's where the human comes in. Okay, so it is about design ultimately, and designing better service and purposefully designing better services.
And then this is looking at a research collaboration. Your poster, who'd like to talk about that? Eva?
So we're trying to figure out how to bring human factors into healthcare in Ireland. And the way that this is being approached, I think, is very innovative in that there's lots of us all coming at this from all different perspectives. So if I just speak about myself, I'm big into communication. That would be a huge thing of mine. And begin to kind of implementing in terms of training, how do you actually make differences on the floor? So that's another perspective, but there'll be other people coming from a more like the design side of things, the ergonomic side of things. There'll be people coming at it from a QI point of view. So how are we going to, marry all that together to make a difference in how healthcare is delivered? That's the challenge.
Fantastic. And what can people do if they want to get involved in this or if they're interested?
Yeah, I think my email address is in the poster, so they can contact me if they are interested in human factors, and if they'd like to be involved in human factors, application of human factors in healthcare. And we aim to develop recommendations how to strategically implement human factors in Irish healthcare. So if you're interested, just email me.
Okay. And just the most important thing you found so far for setting up the research collaborative, Marie?
Just as suppose that, human factors, there needs to be a more, as Eva said, strategic investment. There are some modules like Eva's in RCSI and one in Trinity and Galway at the master's level, but there is a lack of undergrad training in human factors. We really need to think about that and educating people together. So educating nurses, doctors, health and social care professionals together in human factors, that's one aspect. There's no dedicated funding streams for human factors in Ireland, so that's another finding. And despite that, there's a huge amount of research publications coming out of what people are doing. So it's great to see that, even though the dedicated funding isn't there. But it is about aligning and really trying to bring people's expertise together. And it was great to hear today in the conference, an openness to hearing from other disciplines, other industries, other sectors. Like Manas is an engineer, we're psychologists. Like human factors is about bringing different disciplines together and from different industries to try and address safety issues.
Great.
Great.
Like as said, we will put your details up on the website. Is it? Yeah. This is about, it's the call out as well. Your monitor is about trying to get people to join.
Yeah, absolutely. Thank you.
Super. Thank you all very much.
Thank you.
Thank you for joining us today. As I said, all of the QPS TalkTimes, you are able to watch them back on our webpage, and that's available there on the YouTube channel. Look forward to seeing you next Tuesday. Have a lovely afternoon.